Good afternoon from the annual meeting in San Diego. We're pleased to be here today with Dr. Ed Holland. Ed, thanks a lot for being with us this afternoon.
It's my pleasure. Great to be here.
A really important focus at this annual meeting is about the ocular surface. And we know that ocular surface disease is so important, especially in cataract and refractive surgery. Can you explain for us why the surface is such an important focus for us?
Yeah, and I'd like to lump cataract, all cataract surgery I think is refractive cataract surgery, and then of course we can talk about corneal refractive surgery, but I approach the patients the same way. And the reason why it's so important is ocular surface disease has a drastic effect on our patient outcomes.
And in what way does the surface affect outcomes? Is it comfort? Is it refractive error? Is it a little bit of both?
It's definitely both. So if we look at the effects of first of all, underdiagnosing and undermanaging, dry eye and other ocular surface diseases are the main cause of patient dissatisfaction, whether we're talking about corneal refractive surgery or refractive cataract surgery. So a couple things happen. Number one, it affects your quality to hit your refractive target because your data in isn't as good. So it affects our ability to get adequate wavefront aberrometry. It affects our ability to get accurate readings on astigmatism, both in magnitude and in axis. It affects our ability to pick the right IOL power. And that's all pre-op. So we're less than accurate if we have a patient with significant ocular surface disease. Mm-hmm. And then post-op, if you have a patient who has significant changes in the corneal epithelium, they're not going to like your vision. So you could have hit your refractive target perfectly, and they're not going to like their vision. You have a patient with MGD. That patient with an unstable tear film and a rapid tear breakup time, they're going to have fluctuation in vision all the time. I tell surgeons all the time, it's so much more important to diagnose it pre-op for two main reasons. One is you may actually say this is so significant I'm going to delay their surgery. And to me, the no-go sign is corneal staining. If I have corneal staining, I certainly don't want to do LASIK because we know the LASIK patient is going to have some neurotrophic changes for a few months, and if we have staining pre-op, they're going to have significant dry eye complaints post-op. And the second reason is if you kind of look at the eye and say there's some surface disease, but I'll manage it post-op if I need to. The patient who's told that they have dry eye post-op, and you actually had it pre-op and you try to convince them, I saw it pre-op, our problem is your chronic dry eye. They never believe you. They believe their bad refractive outcomes. They believe that their uncomfortable eye is somehow related to the surgeon not doing a great job. So you're much better off kind of setting the table and having the patient understand pre-op that we may have some challenges post-op. And if they are a significant dry eye patient post-op, they're mad at the disease, not you, the surgeon.
That's such a great point, Ed, and I think that a lot of presenters have also spoken to the fact that identifying problems and presenting them to the patient preoperatively really sets the stage and sets the expectations for what they should expect postoperatively. I'm wondering if you can comment on the challenges that I and many other ophthalmologists face when approaching a patient for cataract refractive surgery, let's say, who has pre-existing ocular surface disease, and you're identifying it for the first time on the preoperative evaluation. Perhaps this patient has never received the diagnosis before, and so now you're engaging in a discussion about, well, we need to treat the surface, and we need eye drops, and we need prescription eye drops, and we need omega-3s and plugs, and whatever your regimen is, and they come back to you and say, Dr. Holland, my neighbor came in to have this cataract surgery with you a couple weeks ago. It was bing, bang, boom. He didn't have to go through any of this stuff. So why am I being singled out here, or why do I have to go through all these extra steps?
I really think you have to decide what the patient's expectations are. And let me give you two kind of extremes. So let's say we have an elderly patient with a very dense cataract and some macular degeneration and has a degree of dry eye. The patient is going to be helped most by getting that dense cataract out. That patient isn't a premium